So I think we should get started since we're a little after 8 o'clock. I'll do some introductions and then we'll get into it. So welcome everybody to the October ASJ Journal Club presented by the Young Aesthetic Plastic Surgeons Committee. Tonight we're going to be discussing the article, Do Genital Cosmetic Procedures Improve Women's Self-Esteem? A Systematic Review and Meta-Analysis. So a couple brief reminders. Number one, please mute your microphones at this time. Number two, we want to try to make tonight as interactive as possible. So as we go along, please ask questions in the chat box, or better yet, use the raise hand button, and we'll call on you after our discussants. And if you want to turn on your video and say some words or share your experience, we'd definitely love to hear from you. So tonight I'm also joined by YAPS committee member, Dr. Denise Sarhadi, who will be fielding your questions and also incorporating poll questions during the session, and we'll review all the poll questions at the end. So let's begin by introducing our authors and discussants, and then we'll get into the discussion. So first we have the honor of having Dr. Gemma Sharp, the author of the article, join us tonight. She's a senior research fellow and clinical psychologist at Monash University, all the way in Melbourne, Australia. She leads the body image research group at Monash and has specialized in the field of genital self-image and genital cosmetic surgery since 2013. She also serves as an interspecialty consulting editor for ASJ. Next, we have Dr. Christine Hamori, who is a discussant tonight and also an author on the paper. She's a graduate of Tulane University School of Medicine. She completed surgical residency at BU and then plastic surgery at the University of Pennsylvania. She's in private practice in Duxbury, Massachusetts, and specializes in female genital aesthetic surgery. She's taught her ASAPS course, Labiaplasty and Beyond, for more than 10 years. She's on the advisory board for the Plastic Surgery Channel and is the section editor for genital rejuvenation for the Aesthetic Surgery Journal. She's consistently contributed to the plastic surgery literature, and she's also the editor of a comprehensive textbook on female cosmetic genital surgery. And last but not least, who's celebrating a milestone this evening, a birthday milestone, is Dr. John Hunter. He wrote the commentary for the paper, and tonight he'll be a discussant. He received his medical degree magna cum laude from SUNY Downstate Medical Center, and did his general surgery residency at Mount Sinai and plastic surgery residency at SUNY Downstate. He's chief of plastic surgery and associate chief of surgery at New York Presbyterian Brooklyn Methodist Hospital, and he's also a professor of clinical surgery at Weill Cornell Medical College. Dr. Hunter is a member of the American Association of Plastic Surgeons and serves on the editorial boards of PRS as well as the Aesthetic Surgery Journal. So thank you all so much for joining us tonight. And at this time, we will turn it over to Dr. Sharp to share her screen with us and talk about her article.
Thank you so much for that introduction, Dr. Albert. It's wonderful to be here from Melbourne. As you said, it's actually 11 a.m. the next day, so I'm not in the middle of the night or anything like that, so please don't be concerned. I'll get my slides up as quick as I can. Okay. Can everyone see that? Just a thumbs up?
Yes, we can.
Wonderful, thank you. Okay, so I'm very excited to speak about our latest paper in ASJ, which we were lucky enough to win an editor's choice from Dr. Nahai for, which was really wonderful. And it's called Do Cosmetic Genital Procedures Improve Women's Self-Esteem? A Systematic Review and Meta-Analysis. I want to acknowledge my wonderful co-authors, of whom Dr. Hamori is on the line, so it's great to have her here. And if you want to see more of what I do, my Twitter handle is in the bottom right-hand corner there, and you're more than welcome to follow me and I'll follow you back. Okay, some really quick disclosures. So Dr. Sauer does have, one of my co-authors has some consulting relationships and is also on the board, but this did not impact his authoring of this paper, and none of my co-authors have anything else to disclose. We'd also like to very much thank the Aesthetic Surgery Education and Research Foundation for their wonderful grant, which sponsored this work, and I'm the lead investigator on that. So thank you so much, ASERF. Okay, some really quick background. I'm sure you're all aware that cosmetic genital procedures are becoming very, very popular for, I suppose, the last 10 to 15 years. And we've seen that this increase in popularity really hasn't slowed much. And so it looks like that this is not a passing trend, that this is very much a group of procedures that are here to stay. And in the last 5 years alone in the US, there was a 30% rise in labiaplasty. And self-esteem is one of the most commonly reported motivations for any cosmetic procedure, including cosmetic genital procedures. And so that's why we chose to look at it specifically. But I will say that when we were embarking upon this research, we would have loved to have looked at other outcomes such as sexual satisfaction, genital appearance satisfaction, psychological well-being, but there simply wasn't enough data. So that's why we chose to pursue self-esteem in particular. And so we asked the question, does self-esteem improve after undergoing cosmetic genital procedures? And to that end, we conducted a systematic review and meta-analysis. And we were very excited because we believe that this was the very first one in the world for this particular area of cosmetic practice. So this is a very busy slide, and just to briefly go over it in terms of our methods. So with our search terms, we know that this field has, I suppose, a lot of different nomenclature, and so we really tried to cover off on all the different types of cosmetic genital procedures we could with our search terms. We know that we didn't get everything, but we really tried hard. And we also used a lot of different search engines. And we ended up coming up with 122 articles, which really isn't that much for this kind of search. So we were a bit surprised about that. And then after applying our exclusion criteria, which I'll go through, we ended up with 5, but I'll get to that in a second. So we decided to only go with English language articles because we didn't have the language capacity to have more languages. Apologies, everyone. We didn't include transgender or intersex because we were looking at only aesthetic procedures, which speaks to criterion number 3 there. We also excluded any studies that didn't have a post-procedure assessment or questionnaire applied. And finally, that this questionnaire needed to have some kind of self-esteem measure. So we can see on the slide where the red arrow is pointing, it was really steps 4 and to a lesser extent 5, where we lost a lot of studies due to our exclusion criteria. And what was happening there was that we were reading in these studies that women's self-esteem was reported as improved, but this was generally done by a clinical interview. And that's not to say that clinical interviews aren't really, really important data. It's just that it would be wonderful if a questionnaire was applied as well. So that was a shame because we knew that there was more data talking about self-esteem than we could include in our meta-analysis because we needed the numbers. So as I mentioned before, we ended up with 5 articles out of 122. So it's quite a sharp funnel there. And in terms of the articles we included, there's some really wonderful names in the field in this slide. So Gary Alter, Dr. Gary Alter, Dr. John Miklos, Dr. Marissa Soroka, and Dr. Armin Kalaji. And I was very excited to have one of my own papers in there as well, published in 2016. So again, I'm sorry that the writing is a bit small on this slide, but very quickly, we can see from the study design, there's a real mixture. There's some retrospective, there's some prospective, some have control groups, so a real mixed bag. We ended up with about 395 patients in total, and they're around early 30s average age. The most common surgery type was labiaplasty, labia minora reduction. And in terms of surgical technique, it was really quite mixed. There's nothing we can really take from that in terms of a dominant surgical type. And the follow-up times range from a minimum of 3 months through to 68 months. So quite a big range there and a good response rate from most studies. And I suppose the most important part of this slide is that the self-esteem evaluation differed radically between the studies. So there's single item questions, all worded very differently, as well as in my own study, the Rosenberg self-esteem scale, applied, which is considered to be the most commonly used or gold standard self-esteem scale. So they were the studies included, and this is what we found. So this is called a forest plot if you're not 100% aware of meta-analyses results. And we can see all our studies listed, and then on the right-hand side there are our logit rates. And so most of them are sort of almost near 1 or above 1. And what I'd like to point out is the red arrow, so the diamond bit down the bottom, which is the summary of the 5 studies. And we can see that that's just above 1, in fact 1.23. And what that means in terms of meta-analysis outcomes is that, yes, it looks like the women in these studies had improved self-esteem. So that's a good result from these 5 studies. Okay, so in terms of what this actually means, well, yes, we certainly have some evidence that cosmetic genital procedures, particularly labiaplasty, because that's what the bulk of our studies were about, seem to improve women's self-esteem. And I think you would be seeing that in your clinical practices. But unfortunately, the evidence is not really that strong with only 5 studies. So it really sets, this first systematic review and meta-analysis sets us up for a lot of great future research in this field. In particular, using more quantitative questionnaires, if you can do it pre and post surgery, that's even better. And the type of questionnaire that, pardon me, the type of questionnaire to be used too is really important. So it's great if it's a standardized questionnaire rather than something you've made up in your clinic if possible, and also specific questionnaires. So you would have noticed that I talked about the Rosenberg self-esteem scale for my own study. That's a great self-esteem measure in general, but probably not for this particular population. So even the measures that I'm using aren't 100% ideal. So we direct you to another one of our related papers, which we were lucky enough to get an editor's choice for as well. We've been very blessed with those honours. That was published earlier in the year, and you can see the paper on the slide there, where we discuss what measures would be good to use in this field such that we can do more meta-analyses. And these include the Genital Appearance Satisfaction Scale by Bramwell and the Cosmetic Procedure Screening Scale, Labiaplasty by Veal. They were the 2 measures we would recommend people use routinely in their practice. The issue is that these measures, they don't address sexual satisfaction very well and sexual function. So it speaks to that we still need more specific measures that are comprehensive and cover off on all of the different issues that women who are seeking these procedures are looking for. And that's our in-progress research, which I would love to tell you more about. Unfortunately, COVID got in the way a little bit in terms of our progress, but we hope to have that to you in 2021 so that you've got that comprehensive measure that you can use. But until then, I would recommend the Female Sexual Function Index, FSFI, yep, to cover off on those kinds of issues. So basically, if we're all using the same measures, we can do much better systematic reviews and meta-analyses, and we can be more confident about what we're finding about these procedures, because it looks like women really are benefiting from them. And if we have the research to show that, that would be wonderful. So that's all from me. I've got my contact details there on the slide. Please feel free to get in contact to ask any questions about this research or any other research that I'm doing. As I said, follow me on Twitter. You won't regret it. I'd like to think. And thank you so much for having me. It's been a pleasure.
Thank you, Dr. Sharp. That was a very wonderful overview of the article. So next, we'll turn it over to Dr. Hamori for her thoughts.
Can you see me okay?
Yes.
I always use Gemma as my go-to source when I'm thinking of evaluating the patients that I'm seeing. And I think when I think about all of us doing these kind of procedures, we have to figure out how we can get the data from these patients, effectively give them these questionnaires, and have them actually fill them out, and when they return, fill them out again in an interval that we think they can come back. I mean, my challenges with the labiaplasty patients is I see them at 2 weeks and at 2 months, and I try to see them at 6 months, and they just won't come for that 6-month visit. They're kind of like happy and done and don't want to be seen again. So I think something we have to figure out is how we can maybe send these questionnaires to them and somehow with an incentive have them fill them out. And like Gemma said, we have to figure out what would be the best questionnaires that we'd use. Right now, I mean, I use 4 of them. I use female sexual function. I use genital appearance scale. I use the COPS-L, and I also use the pelvic organ prolapse and urinary incontinence and sexual questionnaire, which I think is important, especially if you start doing vaginoplasties or any kind of vaginal tightening surgery, as well as vaginal laxity questionnaire. I use that as well. I know they're not all validated, but I'm just trying to get more information from the patients as I see them and track it. And I think that's the hardest thing. And I've talked to Gemma about maybe getting a more comprehensive, making a questionnaire that's very specific to genital procedures, that we could maybe, have a lot of these different categories that we could capture the information from the patients in a shorter questionnaire instead of giving someone 4 questionnaires that takes them 15 minutes to fill out. So I do think it's important to offer questionnaires to your patients. All my patients are sent questionnaires as part of the TouchMD platform. They come in as a private document, a PDF that they can fill out that then is uploaded onto Nextech. And we're able to read those, and they're entered into the chart. And I actually, when I'm talking to patients, go over their answers to those questions. And I really feel like I can figure out why they're there. Frequently, they'll come in saying that they're coming for vaginal laxity. It's really labia minora issues. You have to kind of piece that out, and the questionnaires are really, really good at doing that. But it's a matter of making, I think, a more compact, organized questionnaire instead of these long, lengthy ones, and adding self-esteem, Gemma. I think that's important. So.
Great, thank you. I'm sure we'll hear a lot more from you in a few minutes. Thank you very much. And again, a reminder to everyone, please, if you have a question, go ahead and enter it in the chat box. We'll get to them shortly. And finally, Dr. Hunter, who wrote the commentary on this paper, the floor is yours.
First of all, I think that the work that Dr. Sharp, again, the comments before the meeting formally began, is excellent, and I'm on the editorial boards of both, again, Aesthetic Surgery Journal and PRS, so I, especially with PRS, review a gazillion articles, and when anybody puts forward their surveys, the low-hanging fruit is just go, is it tested and is it validated? So, don't start making up your own surveys. So until people like Dr. Sharp in this arena make surveys that have been tested and validated, it's sort of like how all the breast Q stuff, how they've all been generated out of the stuff that my colleagues across the street at Memorial Hospital have done. That's something you just kind of have to be careful about. That's one point I'd make. Number 2 is I only do external genital surgery. So one of the things that I get a little nervous about is commingling external stuff with vaginal rejuvenation and all the rest of it, because these are 2 different patient cohorts. And I know Christine does vaginal tightening and all of that, and Heather Furness does those procedures. So these are 2 different patient cohorts, and perhaps Gemma and Christine can comment on it. And for the reality is for all of this, because you look at Gemma's numbers, you look at, I've done more than 1,000 labiaplasties, which is still, there's guys who've done 3,000 breast augs, 3,000 liposuction cases. There's not a lot of people who've done 1,000 labiaplasties. The reality is that even when Gemma was saying these numbers, the problems with statistics is that they're statistics. So when the number of something is increased 60% or 80%, yeah, but if it was only 6 before, it's not a lot. So her studies are still really small. You know, the biggest thing she had in your survey was 166 patients. The one that she quoted was 29 patients. So a lot of these are small. So the reality, and what I tell patients sometimes is, and Christine is one of the people who I put in the group of, there's a lot of us, there's a lot of people who do a few of these operations, and there's a few of us who do a lot of them. And getting good results, you know, for a lot of this depends on just doing a lot of it. And so I encourage people to get experience learning how to do this operation well, learn how to do, you need to learn how to do a trim operation, and you need to learn how to do a wedge. I love Gary Alter, but not everything in the world can be done with the wedge, but not everything can be learned how to be done with a trim either. But people also, there is not a lot of science behind the assessment of these patients. And I agree with Heather, with Christine. You don't want to be, and I kind of do my, if someone comes into my office and I do my kind of ballpark Mark Gorney evaluation of them psychologically, and if they come in and they have dyspareunia and they think a labiaplasty is going to make it better, sayonara, I'm not operating on you. Even though I'm really good at doing labiaplasties, I'm not going to make you better. That's not, but that's not the point of all of this. And unfortunately, I see people who will, especially now where, well, pre-COVID, everything's a little different. Post-COVID, where people will operate on people because they want to do surgery. And I think we have to be very careful, and that's why I think what Christine and what Gemma have done in this paper, and hopefully will lead to more science about this and something closer to what we have now with breast surgery, where there are validated studies and validated tools like this, where people are assessed. But I do think, and I would ask Gemma and Christine both, we have to be very careful when we need bigger numbers, and we have to kind of separate out a little bit the external genital, you know, the minora and the majora patients from the vaginal tightening and the internal patients. I see Gemma nodding, so I will shut up again. I apologize.
That was great. We definitely appreciate it. Denise, if you want to take it from here and we can review any questions, and if anybody else has questions, please hit the raise hand button, enter them in the chat box, and maybe Denise, we can review some questions and also review the poll answers.
Yeah, absolutely. So as a lay of the land for our kind of audience here today, 65% of us do labiaplasty. And it looks like the majority of us, about 65% of us, do about 0 to 20 or have done about 0 to 20, and a very small percentage, closer to about, 18% have done over 100. And a question that kind of follows on what Dr. Hunter was just talking about, one of our poll questions asked the audience, what is the primary complaint that your patients come to you with regarding why they want to have labiaplasty in particular? 75% of our audience states that their patients cite appearance as an issue. 35%, they can't really fit into clothes that they want into comfortably. 35% have minor functional issues, like just a little bit of irritation or difficulty when they're exercising, and 15% have major issues. So Dr. Hunter and Dr. Hamori and Dr. Sharp, what are some reasons why you may or may not offer this procedure to certain patients? Dr. Hunter, you touched on dyspareunia as kind of being a no-go.
And it's interesting, and I would be curious with Gemma. I wrote this in the commentary because I read all this literature, and it's interesting. In countries, Great Britain would be an example, in Australia would be an example, and I operate, prior to COVID, I had a pretty large number of patients who come to me from the UK. And they would say, in the UK, they would just say the reason they wanted their labiaplasty was because of irritation, whatever. But these were generally, obviously, more well-to-do people or people who just knew of me and they came to me. But they said, in the UK, if you say your issue is functional, you will get it paid for under the healthcare system. So papers written in those healthcare systems will report functional complaints as being the primary motivator. But I think in Christine, I would ask in your practice, virtually everybody in America, if I have somebody coming to me who's telling me their primary motivator, and they got just moderately large labia, and their primary motivator is massive functional complaints, I'm running for the hills, Christine?
Well, I think sometimes, the girls are embarrassed to say
the
women are embarrassed to say that it's purely an aesthetic. They like to, I think it's primarily aesthetic, but it makes them feel less guilty about coming to have surgery in this area of their body if they can equate it with some slightly functional problem. And I think I just think that makes them feel better. I mean, most of the patients have had someone or some incident where someone has made a comment about their labia. It's quite frequent. Some of the girls in the locker room, when they were 6 or 7, they noticed they were different. Sometimes it's a male companion. Sometimes it's just girlfriends. They've kind of had a comment seeded into their head. Then it's become aesthetic. And then I think they start to notice the yoga pants, they notice the different clothing, and they go on the internet, and then all of a sudden it feeds up into their brain that they have a problem, which I agree, some of them wouldn't have a functional problem with the degree of labia hypertrophy that they have. But I think that it's difficult to tease it apart, the functional from the aesthetic. I do believe, I agree with you, that it's primarily aesthetic, but you do have to listen to them. And I mean, many times they have dyspareunia because they invaginate the labia when they're having intercourse. They frequently complain of that. But I agree, if someone has significant dyspareunia unrelated to labia infolding, it would probably be something, a red flag for me as far as operating on them. But I think it is difficult. Yes.
I had a quick question for you, if you don't mind, and also maybe Dr. Sharp. I've been surprised in my practice, and I don't do nearly as many of these as you guys do, but the percentage of patients who've come in who, in talking to them, either have had verbal abuse about their labia, or maybe have had rape incidents in the past, etc. And this is a way for them to maybe move past that. Is that something unique to my small practice, or something you've experienced?
I'm glad the people who've been raped because their labia go to you, Mark, because
not because of, but they seek labiaplasty as a way of coping, perhaps, or moving on after this horrific,
I guess I just am lucky that I have the most normal labiaplasty patients that they come, they have minor functional issues, and they just don't like what's going on, and they have minor functional issues. But
I've had a couple patients that have been abused as kids that have slight enlargement of the labia. And when you start talking to them, I pulled out this traumatic history, and they're not necessarily, I mean, I don't think they're psychologically disturbed. I think they have a big traumatic event that encourages them. I agree with you, Mark, that they want to just kind of forget about the area, and just trimming it makes them feel better. But it's unusual.
Part of it is, I will admit, I do not, you give them 4 surveys to fill out. I don't do surveys. So if I did actual surveys, I would tease out more of those history things than I do. So I don't do the surveys. So I don't delve that much. So I just get sort of the standard, I don't really like what's going on, and I get more of the minor functional issues and the very rare patients that report really major issues. I kind of just run for the hills. So
was anyone surprised to see the 13-year-old that had been operated on in one of the papers? And for those younger patients, do you evaluate them differently? Do you treat them?
I just, on last Tuesday, I did a labiaplasty on an 11-year-old. So, and I get referred now. I do a fair number of young, very young, but if they have huge labia and they are, this was like a 5-foot, 80-pound girl with huge labia. I mean, and I did not even have any hesitancy to do her labiaplasty. But I do now, the only thing I do is this, and I get now referrals from all over the place. So,
Dr. Sharp, from your experience, were you surprised to see this?
I think, I suppose I have quite an Australian perspective on this, and I know that our kind of governing bodies frown upon labiaplasties below 18, but that doesn't mean they don't happen. And it's generally more to do with congenital abnormalities or gross malformations in that area when they tend to get done. I just wanted to pick up on the motivations discussion just really quickly. Like, I think what Dr. Hunter and Dr. Hamori were saying was so interesting, that the way women present their concerns is often functional concern first. Then you have to ask the question, were there any aesthetic concerns? And then they'll go, oh yes, there were. And then you need to ask, are there any instances that have happened to you in this area? And then they'll be like, yes, boyfriend comment. I'm not meaning to shame men in any way, but sometimes it is a boyfriend or a friend. And I've certainly talked to people who have had sexual abuse and used a labiaplasty as a way of healing. I think my concern with that is that I've spoken to them subsequently and the labiaplasty has helped, but there's still some trauma processing that needs to be undergone. And so I think that's where I suppose psychologists like myself can step in and go, okay, so you've started by acknowledging it, by having the surgery, but there's more treatment to be had after that. So I don't think labiaplasty is necessarily a contraindication to having experienced sexual abuse, because it's so common, sadly. But I think probably I would be recommending a psychologist as well in addition to the surgery.
That's great.
No, I would agree with you. I agree with you completely. I would not do the labiaplasty on the people who've had, people come and they start expressing histories of sexual abuse. I don't operate on them. So I make them go do all of that stuff because, you know, I've just been a plastic surgeon for 33 years. So I don't, and I got enough problems at New York Presbyterian Hospital, running the hospital, you know, doing all the stuff I got to do there. I just go, look, your labia are not your problem. Yeah, I don't tell them anything like that. I don't ask I come from the passive school of, I let the patients tell me why they're in my office, and I take their history that way. I give them 5 full minutes. I actually look at my watch and let them speak for 5 minutes of their history as to why they want a labiaplasty.
John, do you use a nurse or you do the questionnaire yourself?
No, Christina, I do it all myself.
Do you ever wonder that sometimes they're not revealing things or because of that you're male? Do you ever think about that?
Well, frankly, no.
Okay.
No, they fill out a history that they fill out themselves, and then when I see them, I ask them, and then I let them speak as long as they want to speak. They come to the office, they find me, they find me, and then they speak. And as I said, I give them like 5 minutes, and then I give my little spiel about what labiaplasty is about, and then not a nurse, but a medical assistant comes in when I do the exam part. I do things a little differently than you do, and you know, that's the way it is. And then at the end of it, they speak to the coordinator, and if they want to do surgery, they do surgery. I don't. It's sort of very kind of, I'm very passive about this whole thing.
But I think Dr. Hamori brings up a good point, because this, you know, the horrific case that I mentioned of sexual abuse, the patient never mentioned that to me once to this day. It was just, she mentioned it to one of the nurses in my practice, and I think she must have felt more comfortable talking to her about it than me.
Yeah, no, and that I've operated on people who have said that to me, and I've operated on people who've said it to the coordinator or to the, I've done that, but I do with massive trepidation. And in those cases, or people who've had psych, I ask them to, have you discussed this with your therapist, or are you seeing a therapist? And generally I will ask them to get, and I will tell them kind of upfront, are you aware there's a possibility, you know, surgery on your genitals might, this is really personal, and it might, I am not an expert in anything related to psychotherapy, but this may, if you had something abusive done to you, my surgically altering your genitals may profoundly reinitiate or it's like scar revisions. We've all done scar revisions that I've done scar revisions where the patient has one expectation and you do what you think is the greatest scar revision, and the patient, it just reactivates their experience of the trauma.
Right.
Dr. Sharp is shaking her head. So am I not correct on that?
Not at all, Dr. Hunter. I was nodding emphatically. I was just going to say I do a lot of trauma work in my private practice, and I see people getting tattoos, other kinds of things when they've experienced trauma. It's like a marking of their body as a way of moving forward, and I think labiaplasty could potentially be something like that.
And there's a fine line between, and that's why I stay away. That's why I only do what I do, and I'm not and that's why I stay away from patients who, any hint of where they think this is going to be genital mutilation is really problematic. And and that's what we have to be very careful about. And as Christine knows, because we've been both on those panels where the American College of Obstetrics and Gynecology and Gemma, too, there's that they have a whole yin and yang, schizophrenia about this. You have, people, writing on one side, and then you have a whole position that they think this is genital mutilation, and not quite, but they're not too far away from that. So
Dr. Hunter, let me interrupt you for 1 second, just because we only have about 5 or 10 minutes left to go, and I know Denise has a little bit more material for, hopefully as jump off points for you experts.
So yeah, a couple. In terms of the kind of what we're going along in terms of self-esteem and things like that, I know that this is a very brief little survey that we had for this journal club, but it looks like from the audience, about 69% of the audience feels like undoubtedly their patients have an improvement in self-esteem after labiaplasty or female genital aesthetic surgery. And none of them responded with no change in self-esteem. So certainly there's something there to it. Whether it's undoubtedly improved or marginally improved, self-esteem definitely does change. And then in terms of function, about 50% of patients said that patients marginally improve with function. So that to me says that primarily, at least in our practices in the audience, that most of our patients are coming in for aesthetic concerns, like Dr. Hamori was stating, rather than necessarily functional. In terms of what your patients say when they come in, I've had patients come in for labiaplasty and they're like, is this normal? Does this look normal? And Dr. Hunter mentioned in his article, and this stood out to me, that most of his patients have labia that are within the normal range of what he's seen. And clearly he's seen thousands and thousands of patients. Our audience, about 72% of us stated that the patients that present have obviously long or hypertrophic labia. And that 11% they would have them be within the normal range. What is your experience for anyone who's interested in responding, and what are your thoughts on that?
Again, I think it's a wrong message. I've done this for a long, long time. So 25 years ago, all of my referrals were from gynecology. I started doing this because gynecologists in Brooklyn didn't want to do labiaplasty. So there was a huge practice that sent women, and they said, you were normal, and they just didn't want to do them. So there's a wrong message to tell women you're normal and you don't need this operation, but it's also wrong to tell them, and Christine, who does a lot of labiaplasties, I can count on, maybe 2 hands, how many women have had actually labia so big that you would want to call them abnormally large. It's like breasts. So I kind of use, and especially with the teenager, the ones that are young, I just say, look, women go into puberty kind of flat-chested, and some come out still, A cup, and some come out like triple D. And some triple D women are totally happy being triple D, but some come out like triple E, and they're not happy, or triple D, and they're not happy with that. And it's reasonable for them to want to get their breasts reduced. And some of the people come out A, it's reasonable for them to want to get their breasts augmented. So there's very, very few people who want to have labiaplasties or minora reductions, because that's mostly what we're talking about, in my opinion, whose labia are so large you would look at them and go like, oh my God, this is so, they are abnormally large.
In my practice, I'd say about 30% have the abnormally large labia. And I'd say maybe the rest have some enlargement for their body, whether they're major or small, whether they're a small person, whether they have atrophy. But I agree. I think, there's a huge variation in normal. It's just what's normal for the patient and what they're comfortable with and how they feel about themselves. And I do think it gives people increased function because it gives them self-confidence, and they feel more confident in the bedroom, and they feel better about themselves and better at the gym. So I definitely think that does improve that. No matter if you're taking off just a little bit of the labia, making them feel better. I think they're all normal. They're like small breasts. I completely agree. And if you want to have implants, you go a little bit larger. And if you want to have a little smaller labia, it's fine to do that. My trouble is when someone comes in with very tiny labia and they want them even smaller. That's a red flag for me.
No, I
comes in and you just, I tell them you have really small labia and they want really, and I worry about body dysmorphic. I'll give them that questionnaire for that. And that's the tough case for me when someone has, in my view, quite small labia and they want them even smaller. That's a difficult case for me to handle. Gemma, how would we handle something like that?
Do you do them? Would you operate on them? I just say, no. You're like, no, I'm not I'm like, I don't need a questionnaire. I go like, no, I'm not amputating your labia. No.
Right.
Dr. Sharp, what are your thoughts?
I think this is such an interesting discussion and is so much of my work. So it's really exciting to talk about it in this forum. And I agree with Dr. Hunter and Dr. Hamori that I think it's the person's own perception of what normal is. And I think just reassuring adult women that they're in the normal range is very unlikely to dissuade them from undergoing labiaplasty. And I think that's what the gynecologists are coming up against, because they may have had that comment when they were 14, 15 years old. They're now 25, 35. They've been sitting with that for ages. They may not have had any comments at all, but they've just been worried. So I think by the time they're coming for surgery, they've thought about it a lot usually. They've had concerns for many years, and they're very unlikely to be dissuaded with an anatomy lesson. And I think, as Dr. Hamori was saying, there is absolutely the chance of body dysmorphic disorder with a genital focus happening here, and it's very important to look out for that. We know that people with body dysmorphic disorder see things differently. Their brain processes things visually differently from people who don't have it. So they might be seeing a very large labia, whereas Dr. Hamori is seeing a small one. And we know that there's no surgery that is going to help that person, and they need to see a psychologist or psychiatrist for that kind of support. Whether they accept that referral or not is a very different thing, but it's important to make it.
So Gemma, kind of following with that, so you mentioned that you don't feel that an anatomy lesson would potentially dissuade someone from not moving forward, but do you think that some sort of classification, I mean, using Dr. Hunter's examples of breast reduction, large breasts, small breasts, they're easy to see. Like you walk down the street, you can compare yourself to other people and kind of get an idea of what's normal or what most people have and not. Whereas with labiaplasty or with genitals in general, most people don't have much of a comparison and they just have no idea what's normal or not. Would some sort of educational pamphlet or classification system, which I know doesn't exist as of yet, do you think any of those things would help patients kind of not go forward with it? I know that as far as plastic surgery goes and aesthetics go, we base a lot of it on our judgment and how it makes the patient feel. What are your thoughts on any of that, even classifying it or helping patients understand?
Yeah, I love that question. I actually have a 2-minute video for teens that came out today. So let me know if you're keen. I think even if it didn't dissuade someone from it, we need this education, as you said, Denise. Like, we know that breasts are different sizes, but we know nothing about genital appearance. I mean, men can see each other at the urinal and in the locker room and stuff like that, but women don't really have that. And I think we're doing a great disservice to young people of all genders if we don't do this education in schools. And I suppose that's what I champion constantly. And that may or may not have an impact on labiaplasty rates. That doesn't bother me so much. It's more about people should know this information and it shouldn't be so stigmatized and taboo. And I would encourage people to check out the Labia Library, the Great Wall of Vaginas, all those types of things. Send your patients there. If they still want to have labiaplasty, then assess them. They've at least got that information. They're making an informed decision.
Mm-hmm. And our poll response was most people in the audience think that 6 centimeters is about too large, but I'm sure that really depends on the patient's habitus and their symptoms.
Well, if there are no other comments or questions from anyone, I'd really like to thank the 3 of you, Dr. Sharp, Dr. Hamori, Dr. Hunter. I know how busy you all are. Thank you so much for spending your evening with us. I'd also like to thank ASJ Executive Editor, Phaedra Kress, for all of her work in making tonight such a success. Everyone tune in next month for the ASJ Next Generation Editors Journal Club, and then we'll be back in December for the YAPS sponsored Journal Club. Have a great night, everyone. Thanks again.
Thanks, everyone.
Thank you.
Thank you so much for having me.
Nice to meet you, Gemma. Thanks.